back to the Hormone Café. I'm Dr. Sarah Pederson. I am a board-certified OB-GYN and I specialize in holistic fertility. Today, we are going to talk about ovulation, this process where the follicle releases an egg. We're going to talk about how do you know if you're ovulating, what is ovulation dysfunction, and what are the different types, and then what are some of the things that we can do to treat ovulation dysfunction. So first off, what exactly is ovulation? If we think of around a 28-day cycle, meaning you start bleeding on cycle day 1, and then your last day before you bleed is cycle day 28, and then you bleed again, most people will ovulate about 14 days before their period. And what ovulation is a process that actually starts 3 months before you even ovulate, because it takes 3 months for your body to recruit a developing follicle. So what is a follicle? As a woman, we're born with all the eggs that we're ever going to have, and our eggs decline over time. And each egg is encapsulated inside of what we call a follicle. So every month, our body picks a follicle, which has an egg inside. Sometimes we use those words interchangeably, egg and follicle, but they're actually slightly different. The egg's inside and the follicle is a little gunny sac that's hugging the egg and holding it and giving it nutrients. Your body will recruit a certain number of follicles every month, and there's some follicles in the backup chamber. And then it picks one of those follicles to be the dominant follicle, and that's the follicle that will ovulate that month. So the follicle that you're ovulating this month started being recruited by your body 3 to 4 months ago. So hormone balance, cycle over cycle over cycle, is extremely important because that has a lot to do with the future follicles that are going to be ovulated. So every single month, your body will recruit a whole bunch of follicles, and then it will pick one to be the dominant follicle and ovulate. And that process is started with a brain hormone called FSH. So the brain hormone taps on the ovary and helps the follicle to grow. And then the follicle will make its own estrogen. And that rise in estrogen also has a positive feedback loop that will cause the follicle to grow and grow and grow. When we're doing an ultrasound, we want to see our follicle be 20 millimeters or bigger before it ovulates, because that's associated with a high quality ovulation. So over a process or over a time of about 14 days, those hormones, that hormone feedback system helps the follicle get chosen and then grow and grow and grow. Sometimes your body can choose 2 follicles to develop and grow and be the dominant follicles. And if those follicles both ovulate, that's how we can get fraternal twins, because now we have 2 eggs. So usually our body will pick 1 or 2 dominant follicles every cycle to ovulate. So that dominant follicle is growing and growing and growing, and that rise in our estrogen triggers an LH surge from your brain. So when your brain has an LH surge, it triggers that follicle to rupture. So usually within 1 or 2 days of an LH surge, then you'll ovulate. So that follicle will rupture, and then when the follicle ruptures, the egg will come out. And that egg will continue down and get swept up by the fallopian tube, continue down the fallopian tube, and then hopefully implant or be fertilized with a sperm in the fallopian tube, and then implant if we're trying to get pregnant. And then if there isn't a healthy sperm, then that starts our luteal phase. So after ovulation, your body then makes something called a corpus luteum. The corpus luteum is what's left over from the ruptured follicle. So the follicle breaks, the egg comes out, then it makes this little squishy looking cyst called a corpus luteum. That corpus luteum makes estrogen and progesterone in the luteal phase. So that helps prepare the uterus lining for implantation. And then that process should take about 14 days. So a luteal phase, meaning from the time of ovulation to the time that you get your period next, should be about 14 days. That means that your body has enough time for the corpus luteum to make enough hormones to support the uterus lining. And then, of course, if we're not pregnant, that whole uterus lining will shed and then we'll get our period. So that's what ovulation is. Ovulation is that process of our body picking a dominant follicle, growing the follicle rupturing, the egg coming out. And then the corpus luteum makes estrogen and progesterone. And that is the last phase of our period. So how do you know if you are ovulating? The traditional thinking is if you're having regular periods, then you're probably ovulating, which is usually true. However, you can have a period without ovulating. A lot of people find that a little bit incredible. Oh, I can have a period without even ovulating? Yes, it's called an anovulatory bleed or a withdrawal bleed. Sometimes your body will make estrogen and then eventually your uterus lining will get thick, and then it just gets a little tired of being so thick and sheds without any ovulation or any progesterone rise, and that shedding can be an anovulatory bleed. So if you have clockwork cycles and they're very predictable, it's likely that you're ovulating, but it's not 100%. So the different ways that we check ovulation, one, we can do it through blood. So all ovulation is confirmed by having an LH surge followed by a progesterone rise. So if we're checking your blood, we can check your LH and see if it's getting high. And then we want to do what we call a post-peak or post-ovulation progesterone. So you want to check your progesterone at least 3 days after your LH surge, check it on your blood. And if it's higher than 4, usually, depending on the lab and the cutoff, but 4 is the usual cutoff. If it's higher than 4, that means that you did ovulate. So one way that we can confirm ovulation is through blood work. Another way that you can confirm ovulation is through urine. So remember that in order to confirm ovulation, you have to have an LH surge followed by a progesterone rise, because sometimes you'll have LH surges, but you'll never ovulate and you'll never get a progesterone rise. It's very common in PCOS, for example. Sometimes people's bodies will try to ovulate and they'll see an LH surge, see an LH surge, see an LH surge, but it will not truly ovulate, and then it won't be followed by a progesterone rise. So when we think about urine, there are some monitors out there like Mira and Anido that can measure something called PDG, which is a metabolite of progesterone. So if you're using urine, you can see an LH increase followed by a rise in that PDG. So followed by a rise in that metabolite of progesterone. So that confirms ovulation. And then the last way that we can confirm ovulation is by an ultrasound. So here at Vera, we do something called follicle studies, where I'll have patients come in and we do serial ultrasounds and we'll watch your follicles grow. And then by the time of an LH surge, we want to make sure that your follicles are 20 millimeters or greater. And then sometimes if we catch it on the right day on ultrasound, you can even see the follicle rupturing and the little water coming out of the follicle. And then 3 days after that, you should start seeing a corpus luteum. So on ultrasound, we see a little shriveled cyst that's producing estrogen and progesterone that confirms ovulation. So we can either do a blood work, urine, or ultrasound to confirm that you in fact are ovulating. Ovulation dysfunction is very common. Some studies show that it can cause up to 25% of cases of infertility or more. And there's different types of ovulation dysfunction. One is called anovulation, meaning you're not ovulating at all. You may have periods or you may not have periods at all, and you're not ovulating. That can be common in people who have really, really low hormones. For example, their hormones just aren't high enough in order to grow that dominant follicle. They don't have enough estrogen to stimulate that follicle. Or people who have PCOS sometimes don't ovulate. People who overexercise or aren't nourishing their bodies enough, sometimes that can put enough stress on our bodies that it suppresses our hormone levels and we don't ovulate at all. The other type of ovulation dysfunction is called oligoovulation, which means that we ovulate sometimes, but not all the time. Sometimes we'll see that in a perimenopausal or moving toward menopause pattern. Sometimes women will ovulate some cycles and not ovulate other cycles. We also see that pattern in something called ovarian insufficiency or premature ovarian failure. People who are going into menopause early or have a really low egg quality, sometimes their body won't ovulate every single month and it will only ovulate some months. And then there's something called LUF syndrome or LUF syndrome. LUF stands for luteinized unruptured follicle, meaning that your body recruited a dominant follicle, the follicle was growing, you had an LH surge, which LH stands for luteinizing hormone. So you had an LH surge, but then the follicle never ruptured. That's why it's really important to confirm ovulation with ultrasounds or blood work or both, because sometimes your body can have this follicle that actually didn't rupture and is just hanging out, and that can turn into a cyst. And cysts can make estrogen, they can make progesterone, they can make hormones in improper amounts, they can cause irregular cycles. So it's very important that your follicle ruptures and makes a corpus luteum. And then the last type of ovulation dysfunction is called a luteal phase defect. We talked about the luteal phase being between the time of ovulation and the time of your period as wanting to be around 14 days. So sometimes what can happen is our bodies can ovulate, but then the corpus luteum isn't complete. For some reason, our body doesn't make a complete corpus luteum, and so we can have a really, really short luteal phase. So anything less than 12 days can be concerning, because that means either our bodies didn't ovulate properly, or we have some kind of a nutritional deficiency where that corpus luteum doesn't have enough ingredients to make enough estrogen and progesterone to support an entire luteal phase. So lots of different types of ovulation dysfunction. It's important that we narrow those down and make sure that you're not only ovulating, but having a really high quality ovulation. And then how do we treat ovulation dysfunction? So in people who aren't ovulating at all, of course, we always want to look at the root cause, right? Why aren't you ovulating? Are you eating in a way that's supporting your natural hormone production? Because if your estrogen is either too high or too low, both of those things can affect our ovulation. So we need to eat in a way that either brings our estrogen down or brings our estrogen up, so we get that healthy flow of estrogen where our estrogen starts low and then goes high. That is what feeds back to our follicle and helps grow a nice, strong, healthy follicle. So hormones being too high or low, it's important to fix those so that we can ovulate properly. And that really starts with nutrition. So we want to make sure we're nourishing our bodies in a way where they're able to make enough estrogen. Especially estrogen requires a lot of different types of nutrients. It requires omega-3s, B vitamins, it does require carbohydrates, it requires vegetables. So diversity is very important because it helps us build enough estrogen in order to ovulate. And then we want to make sure that there's no issues with our brain hormones. Sometimes cysts on our brain or on our pituitary, which is called hypopituitarism or hypogonadism, can prevent our brain from making enough hormones. And if our brain doesn't have enough hormones to talk to our ovaries, then our ovaries won't ovulate. And that can be sometimes made worse if we're not nourishing ourselves, under eating, over exercising, really stressed. That can shut down our brain hormones, and that therefore doesn't give the ovary signals that it needs in order to promote ovulation. And then what do we do about anovulation? Of course, you want to fix the underlying cause, right? So make sure that we're nourishing ourselves, exercising in a way that promotes our natural hormone production and doesn't suppress it or make it worse. And then we want to look at the whole endocrine system and make sure there's nothing wrong with any of the other parts of our endocrine system, right? What are our adrenal glands doing? How's our cortisol and stress levels? How's our thyroid? How's our prolactin? And then any other big causes of inflammation or major types of illnesses that can cause anovulation. Similarly, oligo-ovulation, where we're not ovulating very frequently, that's often from pretty significant hormonal imbalances, because if our body sometimes has enough hormones to ovulate and then sometimes doesn't have enough hormones to ovulate, that means that things are very irregular. So we want to get a good sense of what that hormone pattern is, maybe check blood or urine hormones multiple times throughout our cycle or over multiple cycles so we can get a sense of what the hormones are doing. And then again, also figuring out those underlying causes. Is this something that we're eating? What do we need to do for exercise? Are we sleeping well? Are we oxygenating our uterus and ovaries? Are we stressed? Is there anything else going on? Do we have inflammation from another source? So those are important to tackle so that our body has very cyclic, healthy, regular hormone flow and production. And then LUF syndrome, where our body is making a follicle but doesn't quite rupture. we need to look into estrogen production. For example, is our body making enough estrogen in order to trigger a high quality follicle? And if your body is not, why? One important cause of LUF syndrome or LUF syndrome is endometriosis, because if your ovary is inflamed or your ovary has a cyst, it's going to be able to make a follicle, but it's going to have a really hard time ovulating either past that cyst or through that inflammation. So it's important to check for things like ovarian cysts and endometriosis and other causes of inflammation. And then when we think about luteal phase defects, sometimes we can ovulate but have a really poor quality ovulation. And that we need to really look into nutritional status, because sometimes your corpus luteum doesn't have enough nutrients in order to make estrogen and progesterone, and therefore we can't sustain a full 14-day luteal phase. And then other things is that often we'll use what's called ovulation induction medication, so Clomid or letrozole, which is usually given at the beginning of a cycle, and that helps train our bodies to make more estrogen at the proper times so that your body will go from low estrogen to high estrogen, and that rise in your estrogen will help your follicle grow properly, trigger a proper LH surge, that triggers ovulation and helps complete the process. So even if you are ovulating, if you're not having a high quality ovulation medication can help your body make hormones in proper amounts, retrain your brain how to make hormones in proper amounts so you can have a high quality ovulation. We also use medications called gonadotropins. Those are injections. Sometimes we'll give either FSH or LH. So if there's an issue, our brain hormones are low, as we're working on all of those root cause things, we can help our brains by giving LH and FSH, which is another way to recruit a healthy follicle. Of course, you never want to use those medications as a band-aid. You always want to use it while you're working on the underlying causes. However, it is helpful sometimes to use a bunch of different approaches at the same time so we can rejuvenate our hormones as fast as possible, because as I said, cycle over cycle, it's really important that your hormones are balanced cycle over cycle over cycle, because those eggs that we're trying to recruit in the chamber that your body's going to pick for future dominant follicles, it's important that those eggs have a healthy recruitment process every single month. So it's important that we have a regular ovulatory cycle every month. If you're having irregular cycles, you're worried you're not ovulating, please give me a call. Check us out at verafertility.com. I would love to help you. Thanks for joining us on this episode of the Hormone Café. And our next episode, we are going to be talking about cervical mucus. So stay tuned for our next episode.